One of the things that we want to overcome is that myth that if you are in hospice, that means we're giving up, we're stopping all the medicines. You have this emotional attachment when you're on a medicine. Paradoxically, sometimes these medicines that patients may have been on for years may actually cause burden to the patient. What's important in hospice is not blindly saying, well, you're hospice, so we shouldn't be giving you this treatment. Where is the patient in their disease trajectory? And it's not giving up, it's a transition of how we care for someone to make sure that you have the best quality of life for whatever time remains.
What you're describing is a benefit, and I think educationally we haven't presented hospice as a benefit. We've been presenting hospice as a death sentence. Welcome to the Digital Legacy Podcast, where we talk about death and dying in the digital age. If you ever asked, how do I protect myself and those I love if something unexpected happened to me? You're in the right place. I'm your host, Niki Weiss, and together we'll explore how to protect yourself in a world where both your physical and digital legacy leave a lasting impact. And welcome back to another episode of the Digital Legacy Podcast, where we talk about death and dying in the digital age. My guest today is Dr. Andy Arwari. And Andy, you are down in the Miami area as a physician, palliative care physician?
Yes. Hospice and palliative care, that's the specialty. And I think it's important to clarify that. Because in our field, we have still a lot of people that either want to be identified as palliative care, but the specialty is hospice and palliative care. And, I always highlight that there is no separation. It's a continuum of care. It's the philosophy of care is palliative care. What distinguishes palliative care from hospice is when the principles of palliative care are applied. So I always like to make the clarification. We have what's called concurrent palliative care, and that is when patients with serious illness are still receiving active care, active disease-directed care. They're seeing specialists, they're getting treatments. These treatments are still curative. However, they are now also benefiting and receiving concurrent palliative care. Philosophy of that is supposed to be holistic care provided by a interdisciplinary team. So that is added on to what the patient is receiving and in support of their goals, right? Then there's end-of-life palliative care, which is hospice care, and that is focusing on when we have established within reason that patient's lifespan is now at the very end, they are considered terminal, and disease-directed care or curative care is really not of any benefit to the patient. However, that patient is now going to benefit from that holistic interdisciplinary care, focusing on symptom management and providing the highest quality of life during that final stage of someone's life.
So let's define what that holistic care means, right? Who are the specialists? Who are the professionals that come in and support the families holistically?
So you would have the clinical, so you have doctors, nurse practitioners, nurses, social workers, chaplains, therapists, physical, occupational therapists, speech therapists, pharmacists. The core services really, as defined by the hospice benefit, are the clinicians, the nurses, the social workers, the chaplains, the health aides. And then we also have volunteer services that are supposed to be provided under hospice. Those are the core, right? But you could also avail of therapy services. They're not core, but that is still whatever services can provide or enhance someone's quality of life. Those are disciplines that should be involved in the patient's care whenever they're available. But again, the clinicians, which are the doctors, the nurse practitioners, the nurses, the social worker, and the chaplain, and the health aides, are really what are considered the core services. And those are the people that working together as a team. I always stress this because we still believe, unfortunately, in the hierarchy. There should be no hierarchy. I am part of a team. It's not my team, and I'm not the leader of the team, although, people tend to think that, well, the doctor naturally has to be the leader. No, that's, that if we perpetuate that, then we're really not practicing holistic care. I am part of the team. I bring my expertise, but I also have to rely, and as my colleagues rely on me, on our shared expertises to provide the best plan of care to make sure that we are giving that patient and that family the highest quality end of life palliative care. And that's for hospice. And if it was palliative care, that would still be true. But now we are doing concurrent palliative care. So we're providing that same concept while the patient is still ongoing and receiving treatments and seeing other specialists and seeking other treatments that are not necessarily solely palliative care, and perhaps they're viewed as curative care.
So we talk palliative, right? It just means that you have a terminal disease, but it doesn't mean that you have 6 months or less. You might have more than that, or that you still know that you're at the end of life, but you still want to have antibiotics or some of the therapies you mentioned, physical therapy, occupational therapy. I'm assuming you don't, if you're on hospice though, that those services, medications would not be advised or covered.
Not necessarily.
Educate.
So I want to explain that because I think it's important. So therapy should not be viewed as what's important is, we need to balance what burdens a therapy may provide and what is the value to that patient. So I'll use the example of the antibiotics, for example. Yes, if someone had a serious illness and they had an infection, and from a functional standpoint, they were still, very high functioning, and we think, is there value of providing antibiotics? I would say absolutely. So I think what's important in hospice is not, just blindly saying, well, you're hospice, so, we shouldn't be giving you this treatment. Where is the patient in their disease trajectory? Because that patient can still have a lot of functionality. Their cognition may not be impaired, but most importantly, that infection may be causing distressing symptoms. So of course, we tend to focus on what are the best treatment options for that patient, what is going to, enhance their quality of life. And perhaps the way we look at the antibiotics, unlike what we would do for someone who is purely in the curative sphere, right, is to say, if I provide that antibiotic, am I doing it with the expectation of cure, that I'm going to eradicate the infection? Or am I providing it because as I treat the infection, it decreases the inflammation, it's going to decrease that patient's pain or discomfort? That's what we focus on. So it should never be, well, no, we're not going to, your hospice, you're not getting antibiotics. I think that's part of the goals of care that we need to focus on when we have conversations with patients or their family, and saying, okay, is this reasonable? Is it rational? And what do we hope to achieve? And then, if it's appropriate, if we think that there is value that we are actually going to help the patient, it shouldn't be something that we automatically preclude, right? So we do provide antibiotics in hospice. That's a misunderstanding that, well, you're hospice. And one of the things that we want to overcome is that myth that if you are in hospice, that means we're giving up, right? We're stopping all the medicines, right? You're not going to get your the medicines you were used to. And I think everyone tends to, a lot of most of patients, and I include myself in this, right? You have this emotional attachment when you're on a medicine because this has been perhaps a medicine that you've been on for many, many, many years. It's been, hammered into you. You must take this medicine. This medicine is going to help you. And you become attached to that medicine. It becomes routine, right? You say, this is part of my life, but it's part of what I do every day. I get up, I take a medicine, right? And this is to help me with this. And then I go see my doctor and they check maybe a lab that sees if this medicine is working, or my blood pressure, or, whatever it may be. And so it becomes an automatic thing. So it's hard sometimes, right, to say, well, this medicine at this point in time when we're talking about end of life, of course, is no longer going to help with minimizing or preventing perhaps what we were hoping to achieve with this medicine. I'll give you the example, right? Blood pressure medicines, antihypertensives. The reason we would want someone to have their blood pressure controlled is because we know that high blood pressure over the course of time can damage organs, can cause damage that then would, obviously uh, cause symptoms or cause the quality of life of someone to decrease. So we take we provide these medicines, we take these medicines in the hopes that we are minimizing or decreasing the chances that our organs fail. When we achieve end of life, what are we trying to prevent at that point? We are already on a limited time span. So those medicines at some point really don't have value. And especially when we term some of these medicines are what we call preventive medicines, there's no value to them. And at some point, those medicines can actually become burdensome because the amount of energy that someone may have may be very small. So I always point out, are these medicines providing any type of value to the patient? Are they helping, and what are they doing? Or is it just because the patients become attached to them? And it's a delicate conversation, right? It takes education, discussion, explanations, and it's not a one deal. But the myth around this, right? What people perceive is like, well, if I sign up for hospice, they're going to stop all my medicines. That should really hopefully never be what people understand or view. It should be like, no, we're going to talk about this. We're going to educate the patient and the family, and then we're going to have a shared decision about deprescribing medicines that really are no value. And paradoxically, sometimes these medicines that patients may have been on for years may actually cause burden to the patient. Polypharmacy, unfortunately, is alive and well, as I always say. And anytime that you take more than 5 medicines or more, that's considered polypharmacy. Drugs, medicines interact with each other, and interestingly enough, and one of the things I always teach I have medical students, residents, and fellows, that I would say, when someone presents with a symptom, the first thing you should check are the medicines, because it may be that the medicines that they're taking, or the interactions of some of the medicines that they're taking, may be where the symptoms originate from. So please first make sure that it's not any of the medicines the patients are taking that may be where that are causing the patients to have those symptoms. So always start with the medicines, as I always say.
It's amazing how education driven. I think that if hospice was presented more as not just continuous care, but education as well, that people wouldn't be so afraid of it. Because I am blown away, having been a hospice professional, for so many years, and then stepped away from it for 20 years, and then coming back to see people are still coming in late. They're still coming in 6 days, 6 weeks instead of like 6 months, or doing palliative care and then transitioning to hospice. I'm blown away. It's a phenomena that I don't understand. Do you have insight based on the decades of experience that you've had?
I think it's important to, one of the things that I think we're all obligated, and I hope that, we continue to provide advocacy and education, is to help in the United States, hospice is an entitlement program. And, it's very striking to me that patients people still struggle with that concept. And so it's been it's medicalized. So someone may go to the hospital, they're used to being seen and receiving certain treatments, and all of a sudden that we hit a wall where someone finally brings that up and say, I think we're going to consult hospice, and it's the end of the world because they haven't been prepared, and it's a shock. When in reality, hospice in the United States is an entitlement program. We are the only country in the world that has a fully funded end-of-life service.
We are the only country.
Hospice. We're the only country.
I feel like we need
other
to say
countries
that
have
again. We are
yes,
there are things
but
that
we're
we're
the only
not, but
country.
we are the only country in the world.
that has a fully funded end of
I
life
don't think I
service,
realized that.
and we are funding that. So just to be brief, I don't want to, make this too complex. We fund Medicare Part A, and then when we are deemed to be at end of life, that Medicare Part A fund becomes the hospice Medicare benefit. That's how it's funded. So one of the things I am big about advocating is I want everyone to be aware of that so that they understand this is a benefit that I have. It's an entitlement. I'm not being given anything. It's something I
It's not a
earned.
death sentence
I
either. I think what you're describing is a benefit, and I think educationally we haven't presented hospice as a benefit. We've been presenting hospice as a death sentence.
Yes. And that's where I get to the medicalization. So I one of there's a couple of concepts that I always want to clarify when I speak to patients and families. I always explain my job is to come and provide education about what we do under hospice, what benefits are provided, what services are provided, and so I am not here to make you hospice. I cannot make anyone hospice. What I can do is say, based on what I know, based on all the objective data, my exam, the labs that we have, the consultants, the doctors, my colleagues' opinions, you are eligible for your hospice benefit, for your hospice Medicare benefit. If they're Medicare, and even if they're not Medicare, I say, you do meet the eligibility criteria for end of life care. That's eligibility. But being appropriate for hospice means that the patient or their proxy says, yes, I understand. We're at that point where this makes sense. And so eligibility and being appropriate have to align. We can't impose someone, right, to be hospice. Again, it's their benefit and they have to elect it, but they have to do so based on information and education. It can't be because what's happening, or what I think happens a lot of time, most times, is that it's medicalized. Again, people go to the hospital, they see the doctor, and they're just obviously declining. So at some point, that word is brought up, and so people, of course, it's a natural reaction to say, "Well, no, you're saying I'm dying. I don't want to die." But it's how it's presented, and the fact that it takes time, and it takes education compassionately, but it requires certain explanations to make sure that patients understand, and they are the ones choosing it. So again, I can say to someone, you're eligible for your benefit. We can now turn your Medicare Part A into hospice. Are you ready for
Right.
that? When it aligns, that's when hospice care is going to be provided with the patient's
So
buy-in.
let's talk a little bit about documentation, which you and I stepped into just before I hit record. And that is, as a physician, you're a bit, I don't want to put words in your mouth, but the need for people to be able to provide the appropriate documentation, whether physically or the physical documentation or a digital copy of the documentation, medical advance directive, living will, something that says these are their wishes. What is your biggest frustration right now? Is it because people just aren't planning, or, and I'm curious to see, as a palliative hospice physician, how important is that living will, that medical advance directive to you?
I would say that the most important thing is always the patient's voice, because these documents are guides for patients, and they should be fluid, because someone could always change their mind. They could say, I wrote this down, or someone wrote this, and this is what I wanted at that point in time. But as time moves forward, things may change, and someone say, I said this, but that's not what I
Today.
want in today, right? And so it's important that the most important thing is that these conversations are occurring, that patients' wishes and values are explored, and that these documents obviously are completed and they're updated. because it doesn't help me or anyone else for that matter if someone says, I filled out a living will 20 years ago. Well, is that still valid? Is that what you still want? Well, if we don't know that, it's like, well, this is what it said, and this person filled it out 20, 10, 5 years ago. Circumstances may have changed, or their wishes and values may have fluctuated, and they want something different. So it's important that, and I say that any point that a patient comes into contact with the healthcare system, it should be requested. And I actually think that should be a mandatory of the yearly exam, right? That we do a yearly exam, physical examination. That's what we think that's the appropriate standard of care. To every year you get a physical. Well, during that physical, right, your physician, your clinician, your nurse practitioner, whoever you're seeing should say, okay, well, let's talk about your advanced directives. Have we filled them out? Can we talk about this? Can we explore your wishes and values? It takes time, absolutely.
Decisions,
Um,
people,
but
assessing,
it
who's in your
right.
life today?
It's
Do you still trust
and
them?
most
Know, love, and
right.
trust. Do they
Absolutely.
have the mental capacity to make that decision for you?
And also to ask, right, if in the case that you are no longer able to speak for yourself, who is your designated proxy? Who's going to be advocating for you? Who is going to represent you, and who is going to make sure that we execute and follow your wishes, values, and preferences? So that's another important, aspect. And I always, I think that everyone tends to focus on code status, DNR, CPR, right? But that's not the only advanced therapy. Again, a young person who has a cardiorespiratory arrest, of course, perhaps having full resuscitative measures makes sense. Going to the ICU makes sense. Being on medicines to support their life makes sense. Having, an attempt at that makes sense. As someone enters their final stages of life, those things no longer make sense, and the success rate of them drastically drops. So, we've come to this understanding that we're applying everything to everyone indiscriminately, but we know, right? We have enough evidence to show that these things are not going to help. And so, when you put on the balance there, what are we really providing to patients? Suffering. And so, again, this is not it requires a thoughtful, meaningful, compassionate discussion, exploration of someone's wishes and values, and putting into context where they are in their life journey, and do these things make sense to them? Are these things that they would be willing to undergo, even and what are the burdens of these treatments? And when we do have these conversations, we allow people to at least internalize, reflect, and say, yeah, perhaps not at this point, or I may have wanted this 5, 10 years ago, but not today. That's not what I want. That's not what I would want for myself. And most importantly, right, again, who is going to make those decisions, or who's going to uphold your decisions? And if they're not there, this is you asked me what may be frustrating. Sometimes, I deal with patients who have never had these conversations with their clinicians. They've never had these conversations with their families, and these poor families are stuck. They are struggling, and they're conflicted.
Well, I'm going to
And
jump
they
in. We talked about families. What is your experience working with solo agers? People who are really bedside by themselves. How do they make those decisions? Is
the unbefriended adults,
that what you
and
call them?
that's the befriended
I call them
adults.
solo agers.
And I've had to, and so these are patients that have guardians who are not their family members, who may not have any type of relationship with them and get assigned to them. And I, I just think that they are doing the best they can. They're advocating for them, but they are stuck. They are also conflicted because on the one hand, they're like, well, what is the best course of action? I now feel that I have to make a decision for someone who may not be known to me. And it's just a legal relationship that I have with this person, but not a personal connection. And so there is a tendency to err on the side of doing things to these patients. So
Right.
listen, I'll give you a perfect example. There are patients in hospice, right, that are wards of the state, and they are listed as full codes. And I think that's kind of an odd situation here because,
I mean,
so
so
to
you
be
put like an
clear,
80-year-old, a 90-year-old in a full code? Yikes.
yes, absolutely, right? So
And let
there's
me
a
just pause for
misunderstanding.
those that don't understand why I'm saying yikes. So full code means that if they go into cardiac arrest or stop breathing, that crash cart would come in, CPR, heart compressions. And for those that have never seen, it's a very physical, sometimes violent, there's a lot of activity going on if you're, again, an 80, 90-year-old whose body is very frail. So CPR is not necessarily advisable someone who is fragile. And so that's just to put context why you and I are having such a response to that.
Well, the couple of things I want to mention about that because I think it's important, and I'm a big proponent that we should never, present a discussion about code status initiating if we do this, we're going to crack your ribs, we're going to cause hemorrhage, we're going to you're going to aspirate, if you don't get oxygen to your brain, you're going to have brain death. Not to mention that success rate is very, very low, especially for someone who has advanced serious illness. There's a current statistics that end of life patients who have cancer, their survival chances are less than 1% if you do CPR. However, I think a more compassionate way of approaching this is, again, exploring and helping people reflect on that. And one of the things I point out, I say, well, look, I have to do basic life support and advanced cardiac life support certifications every 2 years. So this is something that I maintain. I've done it for over 20 years. And so I bring up to, patients and their families' attention and saying, one of the most important principles of CPR is you have to initiate it right away. So I always ask, okay, you want to have these things done. So can you please share with me who will be jumping on you, right, and performing CPR? And then is the person that you hope or are designating to do that, are they trained to do that? And so, sometimes I get these bewildered look. It's like, well, what do you mean? It's like, well, yes, if your heart and lungs stop, someone needs to start jumping on you right away, right?
I'm
And
just I'm
performing
just seeing
CPR.
this old, elderly couple where, you know, he's 84, she's 80, he drops down. It's just
That's the reality, the
yikes.
survival, right? Of
Right,
the possibility of survival really is dependent on how fast you
right,
initiate it and the proper
right.
technique, obviously, right? So I've had people tell me, well, no, I'm going to call 911. Well, okay. So in the best case scenario, right? And I'm going to so there's some numbers there that, in the best case scenario, what I know is that in an urban area, metropolis, maybe the response time may be 15 minutes. I always say it depends on the time of day,
Right,
because if
traffic.
they hit traffic, that may not
Right.
be 15 minutes. It may be a little bit longer. You don't have 15 minutes. If your heart and lungs stop and you're hoping and you want to be a full code, someone needs to initiate that CPR right away. So again, I just generally ask them, like, who will be doing this? And so, and I've had people tell me, like, yeah, I didn't think about that, right? Or
Right.
families, say, well, we didn't think about these things. And so that segues into then discussing, okay, is this really what you want? What do you hope to achieve? And sometimes dispelling that myth, because the reality is that people watch TV shows, and and I don't know how they came up with this, but they kind of figured that when you watch TV shows, the success rate of CPR is 60%, right? And that's not true, right? It's way less, especially again for people with serious
Right.
illness. Um, it's way less than that. So there is a disconnect with what people see and the reality of this, and then again, not understanding how these things, the sequence of how these things have to happen and what they have to do. And then you can certainly weave in the information about, look, this is going to cause pain. You will
More
have
damage
these consequences.
than
Yeah,
something.
but I don't. At least that's how I approach it. I don't start the
That's a
conversation that
hard.
way. I just help people reflect. Right? Say like, let's talk about this. Does this make sense? How would you have this done? One of the things I wanted to share with you is that for our Medicare hospice benefit, we cannot condition someone's eligibility and access to hospice based on their code status, because again, it's an entitlement program. Imagine if any entitlement program the government offers you is it can't be conditioned on a requisite. So that is where you say, well, how can someone be a full code on hospice? Yes, because it can't be conditioned on your code status. However,
Educate.
the conditions of participation, which are the rules that govern how hospice works in the United States, there are conditions, what they call conditions of participation rules that clearly articulate that we have to explore someone's autonomy and we need to discuss their goals of care, which means we should be educating them about these advanced therapies and does it align really with their wishes and values and what they hope to achieve. And sometimes there's misunderstandings. Again, people may have certain ideas and they fill in the gap and they say, okay, well, I've seen this on TV, so what's wrong with this? So having it takes conversation, time, education, but it has to happen. And especially when there's misunderstandings, where someone says, yes, I want hospice, but I want to be a full code.
So on that space that really you're on the edge, let's just step into the conversation, another sensitive topic around medical aid in dying, right? So for people that are unaware, they're in the United States, MAID, medical aid in dying, is euthanasia, which is the death with dignity. If anybody's interested in learning more, please go to deathwithdignity.org. Each state, right now we're 12, right? I think Illinois was the last state to pass. I know I live in Pennsylvania. I know that it's on the docket. You're in Florida. So as a palliative hospice physician, you have to tell me, like, how do you educate it's not available in Florida. Okay, so for you, it's not available. But if people bring up the topic, how do you educate them on it?
So I start off by explaining to them that, it's important to explain why. So let's explore, why are they asking for this? What are their thought process behind it?
So let me put this
what's their
scenario. My son-in-law, 34 years old, has astrocytoma currently, right? It's not on hospice, but it's terminal. He lives in Pennsylvania. MAID is not available to him. He's frustrated because he feels like he doesn't have, when the time comes, he has to ride it out versus being able to have that choice.
and you said something very important. It's the choice. And so the choice should not just be binary of, I have access to this or I don't have access to this. It should be, what options do I have? And so I've said this, right? It's not something that I advocate for. I'm not in favor, but I want to clarify why. I think one of the things from a bioethical perspective, as a clinician, as someone who works in healthcare, I am a firm believer that autonomy is important. So are the other biomedical ethical principles of beneficence, non-maleficence, and justice. So medical assistance in dying, I'm not gonna say no, absolutely that should never be offered or it should never be provided, and it shouldn't be a choice. But that's the key that I want to stress. It should be a choice. So as long as patients have access to high quality end of life care under hospice, and they are aware and they're educated about hospice and what hospice can do, and they can contrast that and say, okay, I understand that hospice will provide this. It's gonna focus on my quality of life. It's gonna support me. It's gonna support my family. It's gonna do so under a interdisciplinary team approach. I'm going to have access to interventions and care that's going to minimize or mitigate my suffering. Okay. Or this is the other option that I have. Then I think that we're respecting someone's autonomy because they're choosing, but they're choosing based on education and they actually have a choice. There's something called the Ellsberg paradox, where I'm just going to paraphrase this. By human nature, we human beings tend to choose the thing that we are familiar with and we know, even though it may not be the best choice, and we know that. So if I'm presented with two options and I know this, right? I say, well, I understand this. This is something I can wrap my head around it. And there's this other thing, and I'm really not sure about that. I don't know much about it. We tend to gravitate to the thing that we are familiar and we know about, even though it may not be the best option. So again, if I'm presented with this, let's call this medical assisted dying, and I say, well, this thing called hospice, end of life palliative care, and I really don't know, I've never been educated about, or it's not available, right? That's a resource that in the area that I live is it's not, something that's easily accessible or available to me. I'm going to choose this. So what I advocated for is like, let's make sure that patients understand both options. And then I would be like, okay, we've done due diligence. We have presented both options, and now it's the patient's choice. Does it make sense? I think that medical assisted dying, again, if it's presented to someone who may be suffering, and again, they don't have knowledge of the other choice that they're not familiar with, this is going to be the obvious choice for them,
they have a
right?
disease that is bone cancer, like one of those. The end is painful, and there is most likely a fair amount of suffering.
Well,
Medication, I get it. Like you can with the right with the right doctor. Doesn't always happen though.
that's what it's my role again is to try to mitigate as much as possible those symptoms, and
there's the caregiving
one of the things
issue. Who's going to take care of them? Like, it's complicated.
But I go back to what I said at the beginning. That should never be the view of that palliative care or hospice is just the clinician, and it's just here, I'm going to give you medicine, and everything's going to be honky dory. We want to recognize that, again, the philosophy of palliative care is holistic care, and in order for holistic care to be provided, it's just not me. I'm part of the team. I'm not the whole deal. Yes, I'm a palliative doctor. I need my palliative social worker, my palliative chaplain, my palliative team to complement me and make sure that we are holistically providing the best care possible. How do we address someone who, because again, yes, there's a disease that's causing these symptoms, but that disease also impacts that patient's social life. It may impact their finances. It impacts their relationship with their families, with their friends, their employment. It impacts their spirituality, right? Existential distress is real. So it takes a team to come to, it's like, let's assess this. Like, let's make sure that we're working together. Yes, this medicine's important, but what else are we providing, and are we addressing the other domains to make sure that we're taking care of the whole person? And also providing support to their loved ones. Medical assistance in dying, again, it may seem like this is the only way that I'm going to really stop my suffering, but it doesn't address then
The bigger picture.
the bigger picture and perhaps the support to the family. Again, I don't want to grandstand and say he's like, no, absolutely not. Medical assistance in dying, should is bad, and we shouldn't offer it, and it it shouldn't be legal. I would want people to have access to quality end of life palliative care. I want them to have access to palliative care, concurrent palliative care early. That should be something. That's another thing that we struggle with, and we're still behind. We need to work on making sure that everyone has equitable early access to palliative care, high quality palliative care provided by an interdisciplinary team. That should be something that we still continue to work towards. And then we also need to make sure that when the time comes, they can transition to end of life palliative care or hospice. So we're not there. And of course, if you're in an area or you don't have access to palliative care or hospice care, and medical assistant dying is presented to you and you're suffering,
It's a choice.
how can I possibly say, no, that's bad? I can't do that, right? So again, I want to make sure that people actually have a choice.
And it's all about educate. Two things: educating and planning, documenting, and documentation, right? I mean, that's the project management pieces. Please just document. This was an amazing conversation. I knew the time would fly by between the two of us. So for our listeners, what are 2 or 3 takeaways, or 1 or 2 takeaways that people can do today to start planning for tomorrow, whether for themselves or their loved ones?
I think I would start by saying that they need to think about their wishes, values, and preferences for healthcare. They need to make sure that their wishes, values, and preferences are known. I would say, because it's very easy to hear like, well, you need to speak to your physician. No. I would say let's speak with our families first. Let's make sure our family members, our close family members, the people who are going to be a proxies know what we want, right? Say, well, if this, and these are not comfortable conversations for some families, right, to have, but they are important, especially as we all get older. It was very uncomfortable for me to have these conversations with my parents, but it was funny because my mom designated me as her proxy, and so did my dad. And I said, well, I need to ask you, what do you hope for? Like, what would you like me to do? Well, we had to have that uncomfortable conversation. And listen, this is something I do, right? I do this with patients and families all the time, but it wasn't that easy with my parents.
Even
So
the thousands of conversations you've had with other families, you came to your own
exactly, but
personal family, right?
right. It wasn't that easy, but again, it is important. And at least I'm clear and I know what I have to do, and I'm going to honor their wishes and values. I may not agree with them, right? But I always say that the greatest act of love that you can show someone you care for is to respect them as an individual and honor their wishes, values, and preferences, especially if they're designating you as their proxy or their decision maker in case that they can't make it. So again, I would advocate for people to have these important conversations. I would also ask them, I would remind them, go ahead, bring those things up with your primary care physician, because, they might say, oh yeah, the clinicians may not be comfortable with having these conversations. So sometimes, just nudging them a little bit. I mean, it really should be the other way around, but I think again, these are shared decision makings, and physicians, clinicians. I don't want to just say it's, physicians, it's all the clinicians, health nurse practitioners, nurses, whoever you interact with. I want to have a conversation about my advanced directives. And so I would certainly advocate also for them, as they're having these conversations, to go ahead and complete their advanced directives, living wills, proxy forms,
Please.
post form. DNR forms. Yes, important, right? Because and I always, I would emphasize that the greatest gift that they can give their family is to make their wishes, values, and preferences known, so that then their families are not stuck having to figure it out and feeling like they are the ones making decisions and feeling perhaps even guilt afterwards, right? Because they're conflicted, like, well, what if I made a wrong decision? So it's important, again, to make sure that, everyone's wishes and values
Are honored.
are expressed to them,
Yeah.
and so we can honor them. So that's one thing. And then the other thing I would hope for is we need to do a better job at making sure people understand that hospice is a benefit. It's an entitlement program. I read somewhere, someone said it's a national treasure. And I do believe it's a national treasure. And, it's not perfect. I just want to make that clear, because you hear a lot of stories, right? And there's a lot of things that go right, go wrong. I always say, I promise this, anyone working in hospice is doing it because it comes from here.
Comes from the heart.
It's not, it's right. It's nothing. I mean, the people are in the front line, the clinicians,
It's a calling.
the nurses. It's a calling, right? But I think it's important for people to understand what it is, and then have that, they can make the choice, right? You can say, look, this is not for me. I don't want this. I don't believe in this. Okay, perfect. That's fine. But at least you know what it is, and at least you know it's your benefit. It's your benefit. You work for it. You're entitled to it. It's not an imposition. It's not something that the medical establishment is trying to push on you because they're giving up on you. And it's not giving up. It's a transition of how we care for someone. It's saying, okay, well, these things are no longer doing what they're supposed to do or helping you in the way they're supposed to do. But that doesn't mean we give up on you. We're just going to transition and shift what we do for you to make sure that you have the best quality of life for whatever time remains.
And with that, thank you so much. This is just an honorable conversation, an important one that people really need to not be afraid of, not to be afraid to have it. If someone wanted to get in contact with you or follow you, best place for them to find you? LinkedIn
would be the place.
LinkedIn.
Yes, I advocate about end of life care, hospice, palliative care. I think that these are, I do it because I think it's a way of raising awareness about palliative care and helping people, hopefully other people advocate. I think the more we advocate, the more we educate, the more we raise the awareness, these things become less scary for people, and we tend to, help people understand them and move forward with them. So I think that's a great platform to do so. And that's the one I use. I'm also happy to answer, questions via email.
Which hospital are you at in Miami?
I'm at VITAS Healthcare. I'm a medical director, and again, I'm a hospice and palliative medicine physician.
Thank you so much. Appreciate your time, your expertise, and we'll end our call here. Thank you. Thank you for listening to the Digital Legacy Podcast, where we talk about death and dying in the digital age. I hope this conversation inspired you to take control and plan for the inevitable to protect yourself and those you leave behind. Don't forget to subscribe to our newsletter at digitallegacypodcast.com. Remember, life is full of surprises. What happens after you die shouldn't be. So keep your passwords safe and your playbook up to date.